Thanks, Adira. It's a real joy for me to introduce Dr. Sunita Singh. The Canadian transplant community, as you well know, is highly connected despite the geographic expanse between us. And we've had the great pleasure of working particularly with University Health Network for over 20 years in really world-leading practices in living donation. And Sunita has been a large part of that. So Dr. Singh is a transplant nephrologist in the Division of Nephrology. She's medical director of the Living Donor Transplant Program at University Health Network, Toronto General Hospital. By way of background, there's lots of close ties between Sunita and BC. She completed medical school at the University of Toronto, but then actually did her internal medicine training and was, in fact, chief resident at UBC. She then returned to Toronto to complete a Master's of Science in Clinical Epidemiology and Healthcare Research, as well as additional fellowship training in kidney transplantation and advanced diabetes care. Her research interests include evaluation and follow-up of living kidney donors, as well as management of diabetes in kidney transplant candidates and recipients. I just want to say that in this past month, you will be very soon hearing about 1,000 KPD transplants. Dr. Singh is the current chair of our Living Donor Committee that is led by CBS, and that has been a tremendous privilege. And importantly, BC and really UHN and our colleagues in Ontario are the ones that have really pioneered that work, and that should be a tremendous source of pride for the community. So I just want to congratulate Sunita on leading that. I'm sure we're in for a really fantastic overview of the state of the art in living donor follow-up. And I think this is not just a research interest of Dr. Singh, it's what she breathes every day. And so I'm really excited to hear your talk. Welcome, Sunita.
Thanks, John. Thanks very much for that introduction. I was just telling Adira before we all logged on is that I was actually an internal medicine resident in 2009 at the time of the first KPD transplant and at St. Paul's. And so that was a long time ago, but I think it really was my time at UBC. And of course, that experience was really obviously impactful. So it's really wonderful to be here. I'm very thankful for the invitation. And although I'm not there in person, it's wonderful to be with all of you this morning. I'm just going to share my screen here. Give me a moment. Okay. All right. So as you've heard, I'm going to be speaking about long-term follow-up of living kidney donors. This is an incredibly important area for me and for many others. Before I start, I just want to disclose that I have received some research funding from AstraZeneca. They've supplied dapagliflozin and placebo for a trial that I'm doing. I won't be speaking about any of that today. And over the next 45 minutes, I hope to talk to you about a few things. The first is I want to review long-term outcomes of living kidney donors. This is really underpins a lot of the conversations that we have about long-term follow-up for our patients. I will also want to present some work that we've done in collaboration with John and UBC to discuss preferences and perspectives of living kidney donors on long-term follow-up, as well as additional work to try to get some consensus on how we should care for these patients across the country. And of course, I also want to take a moment to discuss some new models for long-term follow-up care, in particular highlight what we're starting here at UHN, which I hope will be something that will be beneficial for the community at large. And I wanted to take, of course, some time at the end to answer questions. So I just want to start by, of course, this slide. I often start my talks with this slide. Many of you may recognize this photo. This was the first successful living donor kidney transplant that was performed in Boston in 1954. Richard and Ronald here were identical twins. Richard had glomerulonephritis, and they were 23 at the time when Ronald donated to Richard. The kidney transplant lasted 8 years. What kind of fewer people are aware of, I think, is that Ronald lived to age 79, but he did develop kidney failure and required dialysis for about 8 years prior to his death. And so, of course, naturally, as the field has evolved and we have many, many more donors who have gone through with donation, We certainly know more now than we did then. And of course, the question is, could this have been potentially mitigated if it was 2023? So, we of course do a lot of living donations or donor nephrectomies. You can see here data from across countries and globally. Here, this graph represents Canadian activity. You can see here represented by these kind of white bars. This is our annual activity going up to 2021 from CIHI data. We're doing, about 400-ish living donations per year. The US, of course, does about 5,000 to 6,000 living donations per year, and they've done over 176,000 since 1988. And globally, although this is a very difficult number to estimate, of course, but it is estimated that there are at least 27,000 legal living donations done annually, if not more. And so you can see there's a tremendous number of people that undergo this very altruistic act. And so naturally, the question is, how do these patients do over the long term? And so, for the longest time, up until about 2014, the answer was they probably do okay. And that was based on 3 major landmark trials. The first trial was a study out of Minnesota. This was about 3,000 donors, I believe, and they were followed for 12 years, and they looked at mortality rates and kidney failure rates in these donors and found that they were equivalent. Of course, the caveat with this study is that the mortality rates of donors were compared to that of the general population, which of course we know that not all patients in the general population could be donors, or all people could be donors. And of course, for kidney failure, this wasn't really ascertained necessarily using kind of robust methods like dialysis billing codes or transplant listings. So it was probably not a terribly accurate way to capture it. So that was one of the caveats of that study. This was followed up subsequently in 2010 by a study published in JAMA. This was a much larger retrospective study of many thousand living kidney donors, and they were compared to non-donors from the NHANES population study, followed for about 6 years. And this study here, a better kind of control group, naturally, because they were matched to people that were non-donors, but technically could have donated on paper at least, and found that the mortality rates were similar, if not kind of better for donors again. And then finally, a study out of Ontario of about 2,000 donors matched again to non-donors with administrative codes and billing codes, looked at donors over about 7-year period of time and looked at mortality and cardiovascular disease, and found that donors and non-donors seemed to do kind of the same. And so really for a long time, we thought donors do fine, donors do well. And that conversation really changed in 2014. And so there were 2 big trials that were published in 2014 that changed that conversation. I think for most of us, changed how we spoke to our patients about donation risks. So one of these papers was out of JAMA. And this was a study of living kidney donors out of the US. You can see there were 92,000 donors here in this cohort, matched to non-donors, again, pulled from the NHANES population study, followed for 7.6 years. And here the outcome of interest was end-stage kidney disease, ascertained by billings for dialysis, ascertained by transplant listing. So a very robust way to capture that outcome data. Thanks to the way that data is captured in the United States. And this was, a study that showed a signal that donors do have a higher risk of kidney failure than non-donors. And this was that kind of seminal graph. And you can see the cumulative incidence of end-stage kidney disease in non-donors versus donors. The non-donors here, you can see over 15 years have a cumulative incidence of 3.9 per 10,000. Living donors here, higher at 30.8 per 10,000. And that's often where we see that metric of attributable risk of donation at 15 years increases your risk by 0.27. This is where this comes from. So important to note, of course, though, that this study, of course, shows an increase in risk, but important to, of course, keep in mind the absolute risk here still remains low. We're looking at 0.3% at 15 years. And so important to keep that in mind when we're talking about risks, and in particular in the donation space, looking at absolute risks is an important way to frame things as opposed to just looking at relative risks alone. And then secondly, another study out of Norway also similarly found what was found in the US. And this was again a population study, 1,900 donors matched to 32,000 non-donors. Here, the big strength of this study is that the donors were followed for a median of 15 years, so probably the longest follow-up there at that time. And again, these authors looked at mortality, cardiovascular mortality, as well as kidney failure risk. And you can see here for all of these outcomes that I've just described, a higher risk of these events in donors versus non-donors. Again, highlighting here that the absolute risk, particularly for kidney failure, is still low. But nevertheless, a signal for increased risk. You can see here, this is the cumulative all-cause mortality graph where things kind of, the curves tend to split at 10 years. Keep in mind for this study, the number of events was very low. That you can see that's represented by this very, very wide confidence interval, and probably the imprecision here of this estimate is apparent because of that. But nonetheless, two big studies in 2014 describing an increased risk of kidney failure in donors compared to non-donors. And so I think many of us, of course, started counseling our patients about that. Other things that we do discuss with our donors at consultation, of course, is hypertension risk. We know that donors at slightly higher risk of developing hypertension, 16% at 7 years versus 11% in non-donors, typically developing 5 to 10 years after donation. Proteinuria also found to be higher, variable depending on the study, and can be up to 35% depending on what study you're looking at. Seems to be higher in men and those with higher BMI, although that relationship between proteinuria, or albuminuria, I should say, and kidney failure certainly hasn't necessarily panned out or been shown in the donor population as compared to the general population, but important to note this outcome, and something that we talk about with patients. Preeclampsia and gestational hypertension, we disclose to, of course, our donors of childbearing age. Gout, a small increase in risk of de novo gout in our donors as compared to our non-donors. And of course, naturally, there's an increased risk of financial and psychosocial risks, lost wages, out-of-pocket expenses, and of course, issues with insurability, and a small risk of psychosocial issues post-donation. All of those things are discussed. The other important thing to recognize is that the magnitude of kidney failure risk is not the same. So we, of course, have variable risks in our donor population, and you can see this graph really nicely highlights, the differences in risk based on certain demographic factors, particularly here on this slide depicting the impact of race as well as sex. You can see here that men and those of Black race are at higher risk of developing end-stage kidney disease post-donation as compared to women or white donors. This graph again comes from data from the United States, again showing the cumulative incidence of end-stage kidney disease stratified by these factors. You can see here white women, 15 years, have an absolute risk of 0.15 as compared to Black men, where it's closer to 1%. Renal diagnoses also, aside from end-stage kidney disease, also seem to differ by race. A lot of these data on race come from the United States. This is a paper from Krista Lentine from back in 2015, showing you here that the diagnosis of proteinuria, nephrotic syndrome, or chronic kidney disease was again more common amongst those who are African American as compared to those who are white. This was in a large study of about 4,000 or so living kidney donors out of the US. So important to recognize that risk is not the same for everyone, and that there's certain groups that certainly are higher risk than others. I also wanted to bring up the issue of obesity. I think this is something that we are already seeing certainly in my program, and I suspect in many others, of course, in my conversations with my peers. Obesity is becoming far more common. We know that 60% of the population is either overweight or obese. And, I think it's important to recognize that that may potentially impact donor suitability and, of course, donation outcomes. This is a paper out of the US, again, using registry data, looking at kidney failure risk stratified by body mass index, acknowledging, of course, that not exactly the best metric, and has been criticized in many regards as a metric for kind of body weight or risk, but certainly the one that was used in this study. Obese donors classified as those with a BMI of more than 30. And you can see here that there is a difference in the cumulative incidence between those who are non-obese and obese. This is a study of kidney donors, people who actually donated. This was their BMI at the time of donation, acknowledging, of course, that BMI can change over time. Typically weight typically goes up over time as opposed to down, but important to recognize that there's an increase in risk as well. And finally, not everybody does the same after donation. Kidney function is not the same. And it seems to appear that the GFR that you end up with at that 6-month mark post-donation does also indicate or kind of stratify you in terms of risk for end-stage kidney disease. This, again, a study out of the US looking at donors, and they stratified these donors based on their eGFR at 6 months post-donation. You can see here that, again, the cumulative incidence of kidney failure amongst donors. Here, this line representing a GFR of more than 70 mils per minute. This line here representing a GFR of less than 50 mils per minute, again, with low absolute risk, but similarly showing a kind of graded risk profile. And that seemed to be really driven largely by the 6-month post-donation GFR. It seems to dominate that GFR at 6 months seems to dominate the pre-donation GFR. So where you end up with seems to also be important in terms of your long-term risk. So with that being said, we know that, of course, I hope I've been able to show you that the vast majority of our donors do well, but there are a small proportion who do get into trouble with end-stage kidney disease and other risks. Although that proportion is small, I think we want to understand how those donors get there, why they get there, and how do they get there so we can better inform our long-term follow-up programs. And so what do we know about what happens post-donation? So we know that immediately in that post-donation period, of course, naturally, we're removing one whole kidney. Nephron mass is going to drop by 50%. And in the days to weeks that follow, we know that there's a compensation of GFR to 60 to 70% of that pre-donation value. And because of that adaptive hypertrophic response of the remaining kidney, the GFR continues to increase even for many, many years post-donation. And so this was proven and shown by several nice studies. One here I show you by Burke-Siski, very nice work here looking at donors compared to non-donors over a 3-year period of time. You can see here that the non-donors had kind of this gradual decline in GFR of 0.36 mils per minute per year. And then donors, of course, after their donations seem to have this compensation at least up to 3 months 3 years, post-donation of 1.47 mils per minute per year. And nice work out of Alberta showing similar findings, although with a slightly larger cohort. This was a cohort of 566 patients, so a little bit bigger, slightly longer follow-up using administrative data out of Alberta, looking at 5 years post-donation. What happens to the GFR? You can see here that there's an increase for donors here, an increase in GFR in those, weeks to years. You can see by an increase of 1 mil per minute up to 2 years post-donation, an increase of about 0.64 mils per minute up to about 5 years. And it seems that things seem to plateau at that 5-year mark. In this cohort, a very, very small proportion of patients got end-stage kidney disease. I think only 0.2%, 0.8% of the cohort died. So very kind of low rates, at least at 5 years. And it seems, though, that how you compensate post does seem to be affected by how well you compensate in that early period. So what they found is that if you don't compensate that well in those first 6 weeks, you're less likely to have kind of ongoing compensation in the long term. So that's what these investigators showed. So we know that compensation does happen, but at some point in time, certain individuals will kind of have a decline in kidney function and progression to kidney failure, a small proportion. And this figure really highlights probably how that happens, or at least the hypothesis of how that happens. And this graph here was published in 2017. I think just graphically depicts it nicely, and highlights this idea of the second hit hypothesis, which we've heard in many other kind of facets of medicine. But what you can see here is this black line is a normal and a healthy individual who has kind of gradual decline in GFR over time. And then some of these individuals will develop a second hit, for example, diabetes, and kind of have more accelerated gradual decline in GFR. The donors here are represented by this gray line. So they're starting from a lower level of GFR, and you can see here that a second hit that develops may potentially predispose them to a precipitous decline of GFR and to end-stage kidney failure. And so the data seems to support this hypothesis. This is nice work from Arthur Matus that looked at kidney donors and what was their GFR trajectory before they developed kidney failure. There were very few donors in this cohort that developed kidney failure, 39, but 48% of them had it attributed to either diabetes or hypertension. And there's not that many donors in this cohort, which is why there's kind of a lot of noise here, but generally speaking, for those who had kidney failure from hypertension, diabetes, or an other cause here, largely an acute event like stroke or CABG, or an infection, you can see that the GFR stays relatively stable until a second hit ensues, or there's an issue that develops. And you can see here that that tends to happen not in the short term, but really over the long term. And so we know then that time post-donation matters when it comes to risk. We know, based on the data I'm going to show you, that risks are not linear. And so, so the early risks certainly differ from the long-term risks. This is data that comes from the US, again, a large cohort study of over 100,000 donors. And you can see in this cohort that, many donors, not many donors developed kidney failure, but amongst those who did develop kidney failure, where the cause was known, the majority were due to hypertension or diabetes, some due to glomerulonephritis, of course. But if you look at that time frame post-donation, it seems that those who have kidney failure in the first 10 years after donation was predominantly attributed to glomerulonephritis, and those who failed in that time period after 10 years was predominantly attributed to diabetes and hypertension. And you can see here the change and the difference in the absolute risk: 10 per 10,000 at 10 years developed ESKD as compared to 85 per 10,000 at 25 years. And in this cohort, the mean interval of time between donation and kidney failure was 27 years. So really many, many years after that donation. And this here graphically just shows you exactly that concept of time post-donation and why it matters and why that long-term period of time is so important, where you can see diabetes and hypertension, where the cumulative incidence and the development of those adverse events happening late post-donation, especially for diabetes and hypertension, as compared to glomerulonephritis. So with that being said, all of that data really, I think, underpins the importance of understanding what happens to our donors over time. And so I'd like to use the next period of this talk to discuss how we can change the landscape of long-term follow-up of living kidney donors in Canada. And I think we acknowledge that end-stage kidney disease and adverse events are generally uncommon. But we know that our donor demographics are changing. I think certainly we're accepting more donors with hypertension, dysglycemias. Even obesity is an important aspect. This is just a nice graph that shows you in the US what's happening to donors and their BMIs over time. You can see here that the mildly obese, represented by the purple line, and the overweight donors here, represented by the yellow line, that frequency is going up. And so I think we can anticipate or expect that the risk profile may not necessarily be the same as the donor demographics evolve over time. So what do we currently do at the moment for follow-up? Well, I've just put here on the slide some information from various guideline documents. This here might be familiar to many of you. On the left, this is just a screenshot of what KDIGO guideline recommends. And, they recommend a personalized post-donation care plan, as well as the various metrics that should be performed at least annually, including promotion of a healthy lifestyle and psychosocial and screening for psychosocial well-being. In the US, we know that programs are required to submit data. This was put into place in 2013 by the OPTN for at least a minimum of 2 years. And so despite, of course, that mandate, this is still not terribly complete, although I think has increased over time. But certainly I think we can agree, based on the data that we have just reviewed, that 2 years is probably not, certainly not sufficient to ascertain kind of how our donors do over the long term, of course. And then, the KPD document published in Transplantation 2015. This was, of course, a Canadian protocol for KPD. It just says it's the responsibility of living donor donation team to follow up with the donor post-surgery. So that's where, the guideline documents are at when it comes to post-donation follow-up. Typical program practices in Canada, very, of course, variable, and there's no consensus of kind of what we should all be doing. But for the majority of programs, short-term follow-up is offered by donation programs, both surgical and medical. I think the vast majority of donation programs are transitioning long-term follow-up over to primary care providers. Some donation programs may offer long-term follow-up to living kidney donors, but certainly I don't think many programs, if any, have a systematic or formal way to ascertain adverse events post-donation in real time. I know certainly for myself, a lot of times I hear about adverse events happening through kind of my recipient colleagues who are seeing the recipient in their post-transplant clinic. The donor happens to be a family member. And of course, often information is filtered that way. I've had cancer or had a heart attack many, many years afterwards. This is data out of Alberta showing you kind of what happens to long-term follow-up completion, at least in the province of Alberta, using administrative data. They looked at donors and looked at many various metrics, MD visits, measurement of serum creatinine, albumin, and all three together. And what you can see here in this cohort of about 500 donors followed for about 7 years, you can see that the contact with MDs is high. Over 90% or almost 90% of donors are having a physician visit, but you can see that serum creatinine measurements do tend to drop over time, and certainly at that kind of 10-year period of time is certainly suboptimal, definitely in terms of completion for both creatinine and albumin. And those who are kind of having all three markers of care done is quite low over the long term. And the factors that seem to be associated with more complete follow-up, so older donors and those who have higher income status tend to be more likely to complete follow-up in this study. Those who live closer, of course, tend to complete follow-up more frequently, as well as those who had hypertension pre-donation or had a recent nephrectomy. But this really, I think this paper really does show that despite the presence of a universal healthcare system in Canada as compared to kind of our counterparts in the US, it certainly doesn't assure long-term follow-up completion, certainly not in this study. And so there's many studies and a lot of work identifying some barriers to follow up for living kidney donors. I'm highlighting this table because I think it captures nicely a lot of what has come through by both donors and healthcare providers of what they feel the barriers are. Donor inconvenience and direct donor expenses or indirect expenses are certainly commonly cited. Donors often feel that they're not patients, and we've heard this a lot in terms of, and this has been published in previous work, that donors don't feel like patients, they're not sick, and sometimes going back to a tertiary care center or a donation center is not what they want. They don't want to feel that way. Whereas conversely, others feel a lot of reassurance by being followed by a specialist. But I think important to also highlight here from the physician perspective or the healthcare provider perspective, no reimbursement for services. And so I think reimbursement and resources are required to follow up donors. And I think one of the common themes is that the resources are not there to provide long-term follow-up care in the way that I think all of us want to. So when it comes to long-term follow-up care, there's kind of other gaps that I think we all recognize. I think a lot of us don't really have any idea after our patients go off to see their family care providers how complete their follow-up is, what the impact is of the primary care shortage in the country on long-term follow-up care. Certainly, we know that we're in a primary care provider crisis, and certainly certain provinces more affected than others. But nevertheless, what is the impact of donors potentially losing their family doctor or never having one in the first place? And certainly, in many programs, I don't think there's a systematic way for the donation program to be involved if there's an adverse event or there's a health issue in a donor. And of course, the issues of donor collection and consent are ongoing in terms of achieving a state where we can get data to flow from programs to a national system. And I know there's many people on the call who are kind of actively working on data systems nationally. So this, of course, is a work in progress. But of course, finally, and most importantly, I think there's currently no established framework in our country of how to do this for our donors, how to establish a framework. What framework do we have for long-term follow-up for living kidney donors in Canada? So over the next few minutes, I'd like to just highlight some of the initiatives that have been ongoing, work that I've been doing with the Vancouver team to really try to advance the follow-up care of living kidney donors, and I, over the next 10 minutes, wanted to present some data from a survey study that was done to evaluate the perspectives and preferences of living kidney donors on their follow-up care, and also just to briefly highlight some of the outcomes of a consensus conference that took place in November on the follow-up care of living kidney donors. So starting with that survey, what we wanted to understand is, how do donors feel about long-term follow-up care? What do they want? And so this was a cross-sectional survey study of Canadian kidney donors from both Vancouver and Toronto. Any donor who was English-speaking who donated between 1988 and 2021 could participate. This was, work that was supported by Canadian Blood Services, and what you can see here are the demographics of the donors. There were 685 donors who responded. This was an anonymous survey, so unfortunately I can't tell you the demographics of those who did not respond. The response rate was 43%, but you can see here that the vast majority of donors were 45 to 64. They mostly were female and white, but you can see this is likely a group from a higher socioeconomic status. Most had completed college or university. Almost 50% were working full time, and almost 45% had a household income of $90,000. And the majority of donors who responded here were between 2 and 11 years post donation. And so what our donors were actually telling us is that the majority, over 75% of donors, attended long-term follow-up, but the majority were attending follow-up with their family physician. 70% of them attended follow-up once a year, and 70% of them received a reminder by the transplant center to get follow-up. And interestingly, the donors told us that, most of them, over 70%, were satisfied with their long-term follow-up care, and they felt that they had enough support from their healthcare providers post-donation. And time post-donation was not associated with donor satisfaction. But what did come out is that donors wanted long-term follow-up. They wanted lifelong follow-up. Most of them said once a year. But they also wanted follow-up from us, from the transplant centers, when they experienced a problem with their kidney. Most importantly, 82% of them said that, or problems with their health. And donors, depending on their comfort level, wanted either a family physician, a nephrologist involved, or both in their follow-up care. And donors wanted more information and education on diet and nutrition, long-term physical impacts of donation, but most importantly, they were really concerned and wanted to know about their kidney function and that stability over time. And this has come up time and time again in terms of this work, and the subsequent work I'm going to show you is they want to benchmark their own health. And importantly, they also wanted to hear about new research on kidney transplantation or donation. This was a highly motivated group. Most of them were motivated to follow up because they wanted reassurance about their own health. But these are altruistic people. They wanted to contribute to research on long-term donor outcomes. 61% of them wanted to do that. And so, and many of them here didn't have motivation changes over time. 80% actually said that their motivation did not change over time. How that translates, of course, how frequently somebody follows up is unclear, but certainly this group was motivated to follow up over long. Center was associated with follow-up completeness. Those who didn't follow up, very few did indicate that they had major barriers, but a lot of them said, I feel fine. I don't want to follow up because I do feel fine. It's inconvenient, or a small proportion saying it was too costly. Naturally, this study was only serving donors from 2 large programs, so it may not be representative of all Canadian programs, provinces, of course, and this may not be generalizable to programs or places that don't have either a universal healthcare system or where family physician shortages are significant. And so here we had a group likely that had good contact with a family physician. We know that people of higher socioeconomic status, there's an association there between satisfaction with care and access to care. So those are important limitations to keep in mind. But certainly what we are hearing loud and clear from this survey is that donors seem to be satisfied with a family physician-led model of care for those who had a family physician, and they were motivated to do so, but they wanted a donation program or transplant program involved if there was an issue. And certainly, I think the Canadian healthcare system, the universal system that we have, certainly does facilitate the delivery of a family physician-led model of care, in contrast to other healthcare systems. This survey study then led us to move on to doing a consensus workshop. And so this was that second initiative I wanted to showcase today. This was a consensus workshop that took place in November. And what we wanted to do is bring together stakeholders, not only healthcare providers, nephrologists, coordinators, social workers, but also importantly, family physicians who are involved in the care of these patients, living kidney donors to hear the patient voice, of course, and researchers in this space. And so this was done here to try to achieve, some consensus on what we should be doing nationally in terms of long-term follow-up care for our living kidney donors. We wanted to tackle several aspects and get consensus on various issues. The first being that of delivery of follow-up care. Who provides it? Should it be the transplant center? Should it be the primary care provider? The issues of donor consent and capturing data, not only for clinical use, but of course for research use. Follow up of the higher risk donor. I'm careful here not to use the word high risk donor because I think higher risk is probably more appropriate. And of course the frequency of follow up and the parameters of follow up. And so what we did is we started by, presenting a template to our attendees of what we wanted to discuss. And you can see that represented by this slide, which we showed them. And we wanted to tackle all sorts of topics, as I just mentioned. And we broke out into groups led by facilitators. And so I just wanted to show you over the next few slides kind of what came out of that. There was a lot of consensus of what we should be doing, what we want to do. We were very clear with our attendees that we wanted to really tackle and focus what we felt should be done. We all understand, of course, that getting to the how and implementing these kind of recommendations, of course, there will be challenges, particularly when it comes to resources. But the focus here was to try to discuss what we wanted to do, what we should do, as opposed to how we should do it. Acknowledging, of course, that the latter is equally as important. But this was an important first step. Donor consent and data capture, the first thing that I wanted to highlight, this was strongly supported by healthcare providers and living kidney donors alike. They wanted to provide consent. They wanted to share their data. They were in support of a national database, of course, of long-term donor outcomes. This is a quote from a living kidney donor. These are altruistic individuals. I want to be part of something bigger versus just the feeling of potentially kind of left behind. So wanting to continue to contribute through data collection and research. The delivery of follow-up, it was felt that there was consensus that donors should have the choice to either follow up with their primary care provider or the transplant program. This, of course, can vary based on patient preference, where they're living, how far they are from a center, access to primary care, of course. And so this was a view of both donors and providers that having some flexibility of choice here was important. It was also felt that a definition of higher risk donors should be established, of course, to better understand potentially there's some people who should not be followed or should follow with specialist care. And so that was part of the discussion as well. In terms of frequency of follow-up and the parameters to be followed, there was really no consensus on set interval per se. It really was felt that the frequency of follow-up should be customizable based on the risk profile of the patient, or the donor, I should say, the medical need, any complications or health risks. But it was felt that at least on a yearly basis, it was felt to be feasible, minimize loss to follow-up, and doesn't feel too onerous for donors. This was a quote from a physician. It was generally agreed that kidney function should be followed. Metabolic parameters, of course, should be followed. There was some discussion that BMI may not necessarily be the best metric, but some certainly monitoring of weight post-donation and psychosocial well-being. There was consensus that donors should have what we called here in this report here a safety net or a security net. And it's expected, I think, that there will be a referral back to a specialist or a transplant center if there's an issue. But we certainly heard from healthcare providers that they wanted to be able to, quote, engage if there was a problem. And if there's not a problem, the donor has the reassurance that it's being reviewed. And finally, and importantly, there was a lot of support for a collaborative model between transplant centers and primary care providers. There are a lot of patients who have really good relationships with their primary care providers. There certainly was no desire to move away from that, but that transplant centers should be involved in that model of care. There was appetite for helping with follow-up coordination, identification of primary care providers, or having even a network of primary care providers that were involved in donor care. And of course, there was certainly a mention of education of between the transplant center and primary care providers of kind of how donors should be followed, what would be, considered follow-up, the standard follow-up care. So donors also felt too that, as part of this conversation, they were very supportive of collaborative model, largely because they felt a lot of pressure that the donor follow-up was on them. So this was a quote: "In respect to my follow-up care," sorry, there's a typo there, "it has to be on me. A couple of years, I just forgot to do it." And finally, harnessing technology was brought up. I think, the COVID pandemic has moved us towards, of course, a virtual model of care. A lot of physicians say they see more donors willing to come for virtual appointments. Donors didn't like coming to the hospital because they didn't feel they were sick. So this whole idea of virtual care potentially playing an important role did come up strongly from both providers and patients. So what I'd like to do, as I mentioned, these are kind of reports in preparation. I think important to kind of highlight that, there seems to be a lot of consensus amongst healthcare providers and donors of the importance of long-term follow-up care. And I think all of our donor, programs feel the same way, and they want to deliver it. The next step, of course, naturally, is to getting to a point of how we implement it. That leads me to the last few minutes of this talk. I just wanted to take the opportunity just to highlight one model of follow-up care that we're now starting at UHN. It's, just rolling out now. And so I hope to be able to come back and let you know how it goes. But this is just one model that we established when we saw the gaps in follow-up care. How can we potentially bridge that gap? And I hope to just show you today how it works and how we're doing this. And really what it is it's effectively a digital tool where we decided to create effectively a portal here to allow for communications between our transplant center and our living kidney donor. So on one hand, the transplant center would be able to push towards the donor through this interface of personalized follow-up plan, educational materials, for example, updates on research, and of course, follow-up reminders. And conversely, the donors would be able to send to us the outcome of their visit with their primary care provider. So this is not a substitute at all for primary care provider visit. In fact, it works with the primary care provider. We wanted to hear about any health change in health status or questions or concerns the donor may have. So what we do here for donors is the enrollment process would be that at the end of their short-term follow-up with us, they would be offered, of course, the possibility of enrolling in this portal. This is what the interface looks like. Effectively, they would have the option to log in. It's, of course, voluntary. They would be registered for this portal. It's, the goal here is to call this, the portal for life. And so they can stay as long as they wish. And, the idea here is after login, the first page of this portal is a consent. So they would consent not only to participating in the portal, allowing us to review their data, but they consent for us to have access to all of the blood work that their family physician has ordered for that follow-up visit, and for us to capture that data, not only for clinical review, but also for research purposes. They also provide us consent, a voluntary consent, of course, to be contacted for future research. So that's built into that portal. And when they log in, this is the first phase, the first page. Of course, there's a welcome tab just to explain to them how to use the portal. But you can see here a post-donation plan of what their post-donation plan should be. And I'll show you on the next page how that's personalizable and customizable on the back end. They have the opportunity here to be reminded through the portal with an annual email. On the back end, we of course have a registry of all the donors and their donation date. They get a follow-up reminder. And what you can see here is that the administrative user, and in our case, this is our nurse practitioner, inputs kind of what they want follow-up to be. You can add other testing. For example, somebody who's had kidney stones could have, metabolic workup put in here. Certainly anything that you feel is appropriate can go into this form on the back end on the administrative side. And then what donors do is they fill out this form effectively when they see their family physician. This is self-reported data, of course, but they fill out this form. They can open it in real time when they're sitting in their family physician's office. This all gets exported to a table in the back end, and we get a form. That's a form archive. Data can be downloaded, of course, for clinical review, for research purposes. And what this does is our NP would then goes in, reviews the form, and really kind of screens the results. If everything looks okay, they provide a note back saying we've reviewed your form, can keep up the good work. If there's an issue, we don't provide any clinical care over the portal. So this is really effectively a triage mechanism to then kind of pick up the phone and figure out what the plan of care should be, and trying to bring those higher risk individuals back to the program. And then finally, we have, of course, an opportunity for frequently asked questions. These are some that are, just the ones that we typically get asked, but of course, an opportunity for updates, program updates, research updates that can be posted as well. So I've already highlighted, I think, some of the key features of the portal, but this is still allowing for a family physician or primary care provider led model of care. This is just an opportunity in a way for us to kind of have a collaborative relationship with some review as well at the donation program level, an opportunity to bring back higher risk donors. And of course, an opportunity as well to contact individuals for future studies, of course, to have research data for long-term outcome data. But important to highlight here that this portal is a digital tool. It still requires human resources. We have been funded through philanthropy for this initiative, and with our program has a nurse practitioner who is effectively driving this. So it's not just the digital solution. It does require, of course, human resource behind it. Of course, we're just in the early stages of this, so we are going to be capturing metrics, how this goes along the way. And so consent or enrollment rates, the frequency of use, we can of course track through the portal, as well as dropout rates or kind of discontinuation rates. We'll be able to hopefully track adherence to long-term follow-up plans. And of course, another opportunity through this portal is if a patient has lost primary care access, that we'd be able to be informed of that through the portal. And importantly, we also want the patient experience to be captured. What is the ease of use of this? Does it meet the need of donors? And, is the educational information provided to donors through the portal and align with their needs? So exciting for us after a long kind of process of approvals internally to get this up and going, but we're up and running, and we hope to, as I mentioned, circle back and let you know how this initiative goes. And so just to close, to kind of close the loop in this last minute, I want to make sure that we have lots of time for questions. I hope that I've been able to show you today that, living kidney donation is a safe procedure, and the absolute risks of adverse events are low, but the risks are certainly higher than non-donors at an absolute risk level, still low, but not linear, and time post-donation matters. We also know, and I hope I've been able to show you, that the donor pool is changing, and that's going to be important, I think, when we think about long-term follow-up care, and that our donors and healthcare providers want long-term follow-up. And of course, we need to be resourced for this. And finally, living kidney donors, those with a family physician, seem to be very satisfied with that model, but want transplant center involvement. And there seems to be a lot of consensus pertaining to that. And that digital tools is just one example of how long-term follow-up can be facilitated. Still, of course, the success of this, of course, is still to be determined, but we hope that it will be a successful endeavor that hopefully could be expanded beyond just the walls of UHN. So with that, I will end. And I end, of course, with the first donor here. One always wonders if, if the outcome could have been mitigated. We know that our donors often, even with adverse outcomes, don't regret their choice. But of course, it's important to recognize that I think maybe with a long-term follow-up solution, we have an opportunity to potentially change those even small risks. Thank you very much for your attention, and I'm happy to take questions at this time.
Thanks, Sunita, for that great overview. Dira, I'm not seeing the question panel, so
I can see it. So thanks. Can you just maybe stop sharing, Sunita? That'll be a bit easier. Yeah, so sure. One of the questions is there a physiological explanation for the link between living donation and obesity? And are the other studies of the outcomes adjusted for this, especially given the association with hypertension and diabetes?
Yeah, so it's a great point. So, the idea or the thought here is that obesity, may induce a hyperfiltration risk. And so in that study that I showed you or hyperfiltration injury, I should say, but in that study that I showed you, the BMI adjustment, the BMI study I showed you they were adjusting in their models for factors that were known at donation. The problem is, of course, is that we know that donors are certainly at risk of getting events post-donation, and those events were not captured. So if a donor who is obese or overweight were to develop diabetes, in that particular study that I showed you, those post-donation events were not captured. Naturally, of course, very few donors, actually probably none of those donors in that study started their donation journey with diabetes. So it's an important limitation, I think, important to understand that over time, donors certainly can develop diabetes. We know that in a previous study that was done in 2017, I think, by Ibrahim, I haven't shown you this, but I have reviewed this study, that the development of diabetes does happen at the same frequency in donors, we think, as the general population. So donors are not certainly immune to this risk. And it's true. I mean, of course, donors are part of the general population. I think it's important to recognize that weight trajectory also isn't captured over time in these studies. What we know from general population studies is that weight generally rarely goes down, typically goes up over time. So how much of it is obesity? How much of it is the associated comorbidities with obesity? I don't know. And then certainly that study can account for those post-donation factors. All the more kind of reason to study this in far more detail and with more granularity, of course.
Yeah, so I'm going to ask what would be maybe a logical knock-on question, if I may. And so in those people who are donors who then develop risks like proteinuria or hypertension, I imagine things, or have you thought about things like early implementation of SGLT2 inhibitors as a risk mitigation for those, if you could predict high risk?
Yeah, so it's a really, really great question. And what an exciting time right now to be a nephrologist, you know, with this, of course, SGLT2 inhibitors, which are clearly renal protective. And, you know, even the GLP-1s, right? You know, the outcome trials are showing certainly, you know, reduction of albuminuria, renal protective potential, and that's why, you know, the flow trial is ongoing, as you know. Of course, I know, Adira, you're certainly aware. And so the thought here is that these agents certainly may be beneficial, and the whole idea here is we now have these opportunities to intervene. Whereas before we certainly didn't have all of these agents in our toolbox. And so whether or not they would work, of course, to be seen, but, you know, in my mind, why wouldn't they, right? You know, we know that GFRs or GLP-1s are safely used in a wide spectrum of GFRs. Same with SGLT2 inhibitors. So I just started a donor and SGLT2 inhibitor the other day for proteinuria. So, you know, my thought is that with longitudinal follow-up, there's opportunity to intervene. I think there's probably great potential to intervene in a way that we never had before. Not to minimize the importance of ACEs and ARBs, of course, but I think it's a really exciting time to have opportunities to intervene.
Yeah, it's almost easier to use SGLT2s than ACEs or ARBs, I must say. There's also a question about our donors counseled with respect to reduction of animal protein before their GFR drops, and what would, you know, are there like non-medication advice that one can give to donors?
Yeah, I get asked this all the time. And thanks, Ron, for your question. So I get asked this all the time. And so, of course, we know that the data in the general population about protein use is certainly not as robust as in the CKD space. So I actually tell our donors that there's really no good data to tell them what the maximum should be. So I certainly tell them that there's a paucity of data there. I've been generally recommending, acknowledging that the evidence is limited and that there's no obvious kind of data to suggest that protein is detrimental in a healthy individual. And I view donors post-donation as healthy people. And so I just generally recommend 1 to 1.5 grams per kilogram of body weight. Again, that's my opinion. Not to say that they can't have more, but certainly for most people, that's certainly sufficient. And I don't think that until we have more data on healthy individuals and donors on protein use, I see no reason to restrict. And so that's kind of what I've been saying generally, acknowledging, of course, that the data in this space, especially in donors, is really, really, really limited.
Thanks, Sunita. I want to just go to a slightly different space, which is the importance of perspective. as you appropriately pointed out, the studies of relative risk have been widely criticized because the control groups are problematic, and that's not really the issue. So you've appropriately highlighted the importance of absolute risks. But the bigger issue, I think, is that data is largely derived from the United States. And we have no reason to believe that large epidemiological studies which show that we have a magnitude lower of chronic kidney disease progression to end-stage renal disease wouldn't apply to donors in our country. Right now in the United States, there's a tremendous debate going about the fact that there is an absence of long-term care for donors in the US as there is to Canada. And I think that's an important thing for us to recognize the big differences between the US and Canada. The second thing, though, however, is I do think that the data suggests that, we are, as you pointed out, we're looking for philanthropy to enable our programs to have appropriate resources to maintain health after donation, which is really what we're talking about here. As you pointed out in the Arthur Matus' studies and also the Japanese studies, people who donate kidneys have life events as they get older, just like the rest of us. The issue is to help them maintain a healthy life, and if they do develop health complications, to make sure that they're appropriately managed so they don't that doesn't compromise their post-donation kidney function. And I think we have been lucky, if you will, in Canada with people having excellent primary care follow-up and a great safety net of a universal healthcare system. But as the world changes, where we know now 1 million people in our province don't have a primary care doctor, and people move a lot and so forth, that we need to actually advocate that this is now standard of care. And I think it falls into whether we consider these people patients or whether they're at risk. I would say that they're like anybody else. They can develop health issues after they donate that can compromise their post-donation kidney function, and that we need to have an infrastructure that should not be something that we are begging and pleading for policymakers to give us philanthropic support. These donors do deserve to have the safety net of the connectivity that most of the vast majority of them are going to be fine to go on with their family doctors. The other piece of this, though, is it certainly indicates that we need a stronger relationship with primary care. So from the transplant community's perspective in Canada, I think there's a couple of things that come out of the work that we've done together. And number one is universally we hear from donors that they're wildly supported by their family doctors and in a fantastic way. But that always, when you get skewed data like that, I always wonder, who are the donors that we're not seeing who either never got to donate because their family doctors were not very well versed in this and concerned about it, and who are the ones that are not coming forward? So I do think we need to think about our relationship with family doctors and how we maintain that. I also think that we need Canadian data, and it starts with us getting linkages to our end-stage renal disease registry. So we do not have the ability to link to dialysis universally across this country or to national death registers. So we can't even replicate what's being done in the United States. So there's some big policy changes that need to be implemented. And I think this has to be not something that we do as an add-on. It has to be inherent to the programs going forward. I do think it's an overwhelming safe practice, but we do need to change, and we need to evolve and reflect the reality that, look, 1 million people in this province don't have a primary care doctor. And so, we need to adapt to make sure that we have that in place and that strong infrastructure. So thank you very much. I just want to, give perspective that this is an extremely safe practice, but we do need to adapt as information comes available.
Perfect. Thanks, John. Just in the last minute, I know we're out of time, but I completely agree with what you're saying. Of course, naturally, you make excellent points. And I think this resistance, of course, is not coming from donors. Donors want this. They're happy to have their data. This is, they're not like guarding their data and have privacy concerns. They want to share, of course, appropriate sharing of data. That's come out loud and clear in all of the work that we've done. The other thing too is what you say is that we're, in our case, we're using philanthropy. It seems to be so siloed, right? I mean, this practice of living donation, we know is healthcare saving. The financial benefits to the system as a whole is clear, and so yet we are chronically under-resourced to be able to deliver the long-term follow-up care that we want to, despite the fact that it's a practice that we know is beneficial, at least if, not just at the individual patient level, but at the population level and at the system level as a whole. So completely agree.
So thank you for really a stimulating and interesting talk. It generated a lot of questions and also I think helped to inform care and thoughtfulness around this. It's great to see the portal. I think it's something that I'd love to hear how it's going. One of the questions was around the volunteerism of it. I think we have opportunities to do hybrids of both volunteer and essential data collection if we think it through. And I do think from both what you and John are saying is that I don't think it's a hard sell for governments to actually support this. I think it's a matter of having an infrastructure. I think in BC, we might be uniquely positioned to be able to do this as an absolute without philanthropy. But as John points out, if you don't have a primary care physician, what's model B? Right. And model B might be this interesting hybrid use of existing resources, et cetera. But no, thank you very much. And it's great to see you again. And at the peak, we were up to over 65 people. So from across the province. So thank you very, very much for the thought you've taken to put into this talk, but also all the work that you and your colleagues across the country are doing. So thanks, everybody. Bye. Thanks, John.
Thanks, Sunita. Thanks, everybody. Bye.